Well, I see we have Cora here, Aaron Weber, and my old friend Bob Bowman.
Hey, good morning.
Hi, hi.
It is early on the West Coast still, huh?
Oh, it's not bad. It's 8:30 here. Okay, I think we have everybody that we were expecting. We have a what we call commercial relations provider relations committee, and Ramesh is on the call, who is the chair of that committee. Tim Kara is here, who is with Practice Max out of Arizona. Alicia is the enrollment specialist from a large RCM company out of San Diego. And then I'm as you, Aaron and Bob, you know me, I'm with the HBMA, as is Haley and Courtney. So what we'd like to get out of today's meeting is we'd like to get a better understanding of the work of CAQH Core and how we can participate in that effort. We'd also like to better understand the products and services of CAQH Core and how we can help improve them, and most importantly, how we can help deploy them to the revenue cycle management industry. So with that, I think, Aaron, do you have a presentation?
I do. Here, let me share my screen.
Okay.
All right, let's see. Sometimes when I go into the, oh, all right, I can still see you guys. Does this look okay?
It looks good.
All right. So let me give you, what we're going to do today is give you a little bit of background around CAQH and Core and who we are. Then Bob's going to walk through some of our latest initiatives and operating rules, and I'll wrap up with some of our measurement efforts and our work on price transparency, particularly around the advanced explanation of benefits requirements. And we're going to pause kind of throughout to hear your thoughts on these topics, understand how it's impacting your organizations, and kind of brainstorm a little bit around how we can collaborate on improving, these particular areas of focus.
And Aaron, would it be okay if at some point some of our members have observations or concerns or experiences that aren't particularly positive? Is it okay that we would bring them up?
Yeah, that's really actually very helpful for us. So, operating rules are really business rules that sit on top of the administrative transactions in healthcare. And the purpose is to create more uniformity and standardization in how those transactions are used. I would say the goal of the operating rules in particular is really to benefit providers. And a lot of the benefit goes to providers. So we want to hear particularly where your client pain points are, pain points within your own organizations, because that helps us think about where we should be focusing our future work as well. So a little bit of background around CAQH and Core. CAQH is a nonprofit alliance of health plans that was founded more than 20 years ago to address to improve and streamline the business processes in healthcare. And we're really divided into 3 separate initiatives. The first is our solutions arm, which is our product arm. And I know, Brad, you've had some other conversations with those folks, but we have a lot of products focused on provider data management, member data, as well as a FHIR endpoints directory. And so all of those products have one thing in common, and that is they are products where if health plans and providers work together going through a single utility, it really reduces burden and cost on the system overall. The second initiative is our explorations, our research arm, and that group puts out the CAQH index every year, which measures industry progress in automating transactions and moving towards a more electronic revenue cycle. And they publish other briefs and research pieces throughout the year as well. And then today we're going to talk about CORE. CORE was founded shortly after HIPAA was passed. HIPAA included requirements, as you all know, to use certain administrative standards for key revenue cycle processes, eligibility, claims, EFT, ERA, and what happened shortly after HIPAA passed was that even though organizations were starting to use the electronic standards, how they were using those standards still varied quite a bit from organization to organization. So if a provider was trying to electronically check eligibility with Aetna, they would get a different response than if they were working with Humana. And so the industry came together to form CORE to create business rules or operating rules to create more alignment in how the plans were exchanging this information. We have rules around, for example, with the eligibility transaction, the data content within the transaction. So requiring a lot of patient financial information around copay, deductible, remaining balances, as well as infrastructure requirements. So it's the core operating rules that require eligibility to be conducted in real time. In 2012, we were named the National Operating Rule Authoring Entity by the Department of HHS, which means that some of our operating rules, like the eligibility operating rules, are federally mandated for all HIPAA covered entities. Other sets of our operating rules are for voluntary implementation because it makes good business sense for organizations to implement them. We see our role not only to convene stakeholder work groups and subgroups to develop and vet operating rule requirements, but also to ensure there is broad industry awareness of the operating rules, to drive adoption of the operating rules through our certification program. And more recently, we've really been focusing on measuring the impact of the operating rules through the CAQH index, our pilot and measurement initiatives, which we'll talk a little bit more about later today. We are governed by a multi-stakeholder board, including equal parts providers and health plans. So nothing moves forward unless those two groups agree, which can make for some difficult conversations from time to time. And we are also advised by all of the standards development organizations, as well as WEDI, which is a advisor to HHS in this space. We have more than 100, I think more than 110 participating organizations that identify representatives to participate in our subgroups and work groups to develop the operating rule requirements and vet the operating rule requirements. This number is often changing, but we have a good mix of health plans, government entities, both state entities and federal entities, providers, vendors and clearinghouses, as well as associations and other SDO and advisor organizations, including HBMA, that has been a longtime participant with CORE. We currently have 8 sets of operating rules that have been completed and approved by the CORE participating organizations through our voting and approval processes. 3 of those sets of rules are federally mandated. So that's the eligibility and benefits, the claim status, and the payment and remittance operating rules. But the operating rules really impact the entire scope of the healthcare revenue cycle, from eligibility all the way through payment and claims, and also address some of the transactions that are occurring between health plans and employers around benefit enrollment and premium payment. I'm going to pause here, see if you all have any questions about the background of our organization, and then Bob can talk about some of the latest areas of focus for the participating organizations.
Aaron, 2 slides back, where would HBMA, where do we fit in? Which?
You should be listed under the other category right here, Healthcare Business Management Association.
Okay, so we're an other, all right.
You're an other, but you're an important other, along with all of the associations. You know, in particular, on the provider side, the AMA, the AHA, the MGMA, and you all and HFMA as well really play a key role in representing the voice of small provider organizations that don't necessarily have the resources to participate in CORE on a regular basis. You know, certainly their vendors as well are participating. We really value the input from the associations.
I'm glad you pointed that out. Ramesh is on the board, and we have an invoice that we need to pay to make sure we stay active. So I wanted to make sure we understood where we fit in.
Thank you. Erin, quick question. I know that you said that some of the your processes are mandated by the federal government, by the HHS.
Mm-hmm.
I'm just looking at, for example, when we look at the ERAs, electronic remittance advices, and we're looking at some of the CARC and RAC codes, the remittance advice reason codes and the claim adjustment reason codes. And that itself, we don't see a standardization of how those particular codes are used. So although it is mandated, when each organization is using it according to their own convenience, how exactly are you standardizing things?
That's a good question. We do have an operating rule called Uniform Use of CARCs and RARCs, which identifies 4 business scenarios and code combinations within those business scenarios that plans are required to use if the denial or adjustment falls within that business scenario. And it's really trying to address that 80-20 of most situations that are occurring. Those code combinations are federally mandated. Bob's going to talk about our maintenance process because the codes are consistently being updated for 3 times a year. So we have a maintenance process around that. If you are finding that plans are not using these codes consistently, that is consistently or in accordance with the core code combinations, that would be a violation of HIPAA. And so there is an opportunity to submit a complaint to CMS through their, it's called ASET, ASEST process, I believe. And they will investigate, and typically they don't necessarily charge penalties to the non-compliant organizations, but they work with them to identify a remediation plan to ensure that they are in conformance moving forward. And Bob, I don't know if you want to speak to that. Bob actually leads that initiative, so I probably should have.
Yeah, definitely. I think it's a really good point, one that we do hear from not infrequently, where plans are still challenged with meeting some of the goals of the operating rules and some of the requirements of the operating rules, especially when it comes to the core code combinations. Right, we look at, in those core code combinations include the CARCs, the RARCs, and the group codes to make it much easier for providers to understand that message for the denial or the payment adjustments that's taken place. And as I mentioned, there are 4 business scenarios. Usually it is the 80-20 approach that we've taken, but we do know there are many, many other scenarios where health plans will adjust the payment on a claim or a claim line. So we will be tackling those through time. We have a market-based review that we do as well, where core participating organizations have the opportunity to identify where those challenges are, and then we can have those discussions to add potentially new business scenarios or new code combinations to the regular business scenarios, the 4 that we already have, to make those adjustments for the industry. So we do have a process to help tackle some of those problems.
So do you have means, like, for example, when you did speak about the 80-20 rule objective, but again, from consistency of interpretation that's there, is there something that you can trace it back to that 80% of the things that we're looking at, the guidelines of how this code combinations are used, something you can trace it back for the providers to be able to come back and say, okay, if this combination of sets are used, this is what it means. It has to be consistent across, at least a broader guideline.
Yeah, we definitely have those conversations are available for participating organizations through our core code combinations task group, because the plans sit on those calls as well as the provider representative. Any core participating organization can sit on those calls, and we have those agenda level conversations when there is misinterpretation, when there's issues. We talk about that level. We can go down to that level with the participating organizations.
Thank you.
Yep. Yeah, we definitely know, and we've had this topic quite a bit. I know when I presented in the past for HBMA at your national conference, this is usually a highlighted topic that really is important for folks in this space, because understanding and having that uniform, consistent messaging from health plans, all across all of them, makes it much easier for us when we're dealing with the revenue cycle on the back end and adjusting our AR.
That's true.
Yep. Now I'll move into some of the spaces that we're working in currently and what we've just done over the last year or so. Again, as Aaron mentioned, we do write operating rules to meet needs, and we identify those needs from our participating organizations and from our board members. You, the participating organization, helps us, really the facilitator of discussion. We do our analysis, our research, our environmental scanning on topics, and we help to align both the standards that exist in our space as well as the different technologies that exist. Again, through our vendors, our clearinghouses, health plans, and providers all kind of coming together to address those needs. We do that not only through developing operating rules, but also through pilot studies and measurement studies. We work with, and you'll see this on our website, for example, we work directly with Cleveland Clinic and their vendor and a couple of health plans in Ohio just to understand some of the needs and challenges they have for prior authorization. And then we went and solved them. Their vendor developed a real-time solution for the use of the 278 transaction. We tracked and trended. We have education sessions with those entities, with those health plans, with Cleveland Clinic, to understand exactly what they've done to be successful in implementing a standard, their associated operating rules, and then how that has eased the burden of the transaction or dealing with those interactions that a provider has with a health plan, and how we remove that burden from both sides of the coin, but mostly from providers. So you'll see a lot of that study and measurement studies that we're doing over the last couple of years and continuing that on. Some more exciting news I'll share, come back to this in a minute, because we have some interesting claims attachments pilots that we're going to be kicking off too this year. But on the next slide, you'll see that really what, yeah, there we go. We've been working on attachments for both the prior authorization as well as attachment for the claims. We've looked at very specific challenges that providers have in this space when dealing with health plans, whether it's electronic or fax or paper or mail-in, whatever those means of submitting those attachments are. We've been trying to tackle some of those harder problems that providers are experiencing. We've also realized that our rule for eligibility is a little old. We've last touched eligibility transactions back in 2008. So the task group started last summer. We finished that work, and again, these rules were just approved in May by our board. They also review and we have revised the requirements for our eligibility transaction. Last but not least, we've also revised our rules for system availability, really to make sure that the system is available 24/7, really for providers to ensure that they have access to the data when they need it most. We can get into a little bit of the detail for the rule requirements that we have for prior authorization attachments. We include requirements for what the payload is. How do you actually submit an electronic attachment to a health plan? We have requirements for the X12 transaction as well as other transactions. So if you're already using the CCDA from HL7, or if you're ready to go to FHIR, or if you're submitting a PDF or a TIFF or a GIF or a Word document, we have requirements to uniform that process, to standardize that process. We've also looked at infrastructure requirements related to the submission. So what should it look like as it comes in, and what should you as a submitter of this information expect from the health plan? And we've also looked at some data content. Today, many of these types of transactions for prior authorization and for claims, it's bifurcated. You submit an inquiry for the service for a PA, or you submit the claim, and then it gets pended. And when it gets pended, then you understand exactly what might be needed to release that pend on the PA or release the pend on the claim, and you submit that. So it's different time frames, and it's different submission methods, and it's different ways of doing it. So you have to be able to reassociate that initial inquiry or that initial claim with the attachment that follows. You, the provider of billing service, as well as the health plan, they have to be able to reconnect these things. So we've talked quite a bit about what exactly that data content is for reassociation, and making sure that there's that consistent reference data between those different transactions that take place. So we, on the next slide, you'll see that we have very similar findings and requirements for our healthcare claims. It doesn't matter if you're using X12 or not. The infrastructure is going to be very similar. We've added some infrastructure requirements as well, and to ensure that everyone who submits a claim knows and understands when an attachment might be required for that type of service. So there are some electronic requirements that a health plan has to follow to ensure that they provide that information beforehand. We also, as you can imagine, a reassociation component still has to take place. So we ensure that there's that data content requirements for reassociation for the claim and the claim attachment. We also require health plans to use the most appropriate LOINC codes when requesting additional information. So there's that requirement. There's a certain set of LOINC codes that's specific for HIPAA and for the HIPAA transactions to be used. So we include those sets of LOINC codes. So again, to better automate the systems of inquiry and response and request and response. So health plans can begin using those, codifying what is required so that you, when you're in your EHR, you can more quickly locate that specific data point or that specific attachment and then send it in. So expediting the back-end process of finding those attachments and that data to ease the burden on billing. As you can imagine, on the next slide, just a quick synopsis of some of the benefits of adoption. Again, as we continue to see EHRs and PMS systems becoming more integrated, that data is also becoming more integrated. It's a challenge. We have to make sure that we're keeping up with the needs of the industry in this space. So we think the requirements will help do that. We also have the key infrastructure requirements, again, to ensure that the expectations of trading partners are met. So, if you send in an attachment, it will be acknowledged. It doesn't fall into a black hole. We also, the reassociation component for claims and prior authorization, because we would all love to have everything as simple as an Amazon purchase, right? Click here and it comes to you. But we know that claims and prior authorization are still very much a batch process. You submit it and you might not even know it's been sent and received until you get your remittance advice, right? Until the 835 pops in a week later. So the reassociation really can help drive that automation component as it builds through time, because we have to be able to support the batch process that still takes place today. When you submit a claim, then you go back and submit the attachment a week later because you don't know it's pended for the attachment until that remittance advice comes in. And again, all this is help to expedite the process of delivery of care and help improve that process. Moving into our eligibility update, I know this might be really important for you as well. We looked at and found of the 20 some odd potential different opportunity areas for reviewing and updating our eligibility and benefit data content rules, 6 items came up to the top that we moved forward with and approved. This was pretty contentious, right? Because this is really substantive remediation efforts by many health plans and clearinghouses to make these types of edits to their systems. But after the discussion, particularly with our provider participants, those folks kind of looking and really need this data, all of these were approved at a very high level of consensus. I think the lowest one of these was 88%, which is really kind of unheard of for providers and health plans kind of coming together and agreeing on what needs to take place, what changes needed to take place, and then to actually be successful getting that discussion had, understanding the challenges, and then actually getting approved, right? You can imagine how sometimes it's herding cats, right? That's what CAQH core does. But you can see here, we include procedure codes now can be submitted on an eligibility inquiry. So a specific CPT or HCPT code for these 4 types of categories of service. So if it's a physical therapy code, an occupational therapy code, a surgery code, or an imaging code, health plans, again, once they've implemented the rules, we be able to submit specific benefits in the eligibility response for those services. We've also added 71 discretionary and 55 new STC codes. Today, you're probably just sending in a 30, that generic dump code, and getting back a generic response. We now have 178 STC codes that are specific for specialty. So you can send in dental, you can send in chiropractic, you can send in any sort of specialty. There's 178 code. I think there's 220 codes total. The core requires 178 of them to be supported now. So health plans can go drive and drill down into those specialty benefits and tell you exactly what is left for those benefits. What is the remaining deductible? What is the deductible? In and out of network variances for those benefits. All of those can be returned because we've expanded our STC codes. We've also updated the telemedicine requirements to using the 02 and 10 to indicate that the service or benefit is available for telemedicine. So we know this is a huge thing through the pandemic, and CMS has made updates to the way that they do it, and the commercial industry has agreed to follow that guidance that CMS has. So we've also included that in our operating rule. The three other opportunities that came to fruition and passed through our voting process is remaining coverage benefits. The ability for health plans to return exactly how many are left in a benefit is important, especially if those benefits expand calendar year or benefit year. Many benefits we think of might be January to December, but we know that there's a big turn in July to June, as well as some federal accounts are October to September. So it's not necessarily calendar year. Benefit years can vary. So remaining coverage benefits are important for providers to understand how many are left, how many chiropractic visits do you have left, how many PT, OT, those therapy visits are left. You don't want to schedule if you don't have that benefit, right? We don't want the providers to be stuck with not being able to bill those services. We've also updated our tiered benefits to include information back to the provider if that member is in a particular tiered benefit or if the provider is in a tiered benefit in regards to what the reimbursement rates might be. Again, these also indicate in and out of network, exclusion preferred networks for the inquiring provider. So all of the information can now be returned in the eligibility transaction, making it much easier for you to understand what that benefit is and what that potential for reimbursement will be. And last but not least, a very contentious one, as you can imagine, is actually to use the indicator that is available in the standard for prior authorization and certification. Today, it is an optional field. No health plan has to return it. With this rule update, health plans will have to return if a benefit by the STC code or by the HCPCS or by the revenue code or by the diagnosis code, if you submit it that way, they'll have to return it if it is specific. And so it's a yes, no, or unknown. They'll have to return that indicator to let you know for sure that it is required for PA. So that way you can fire off the PA immediately. Right when you do the eligibility transaction, you'd have that indicator return, yes, a PA is required for the service. You can start that prior authorization process immediately. So it helps expedite the delivery of care.
And that requirement is now been passed by your board?
It has been approved by the board, yes. Okay. So I know we'll probably have a question about the timing. For us, for CAQH Core, as soon as we publish the rule, which the rule is now published, it is considered published because it's on our website, the industry can begin adoption. And we track that adoption through core certification. So now health plans, vendors, clearinghouses can go through core certification to remediate their systems to meet these requirements. So it's now in the implementation phase, and we're working with the industry for not only awareness, like the example of this presentation, but also to get the health plans to remediate their systems, schedule this into a release, and then release it and then certify their systems. So that's what we're doing over the next year.
Robert, just to go back a little bit, how many of the EHR vendors are actually members of CORE?
The EHR vendor, we have quite a few of them. And many of them do sit in our work groups and task groups. We have the list here. All the big ones are generally here. And they are, as you can imagine, are very vocal and very interested in the work that we do. Some of them sit on our board.
Both Athena Health and Epic actually are on the core board.
I mean, those are the big players. That's what I'm trying to see when we start looking at the smaller players, because yes, we understand that they're the big ones, but then a lot of providers do use the smaller players, etc. And I don't see a sort of representation of the smaller ones. Is there a reason why that is not happening?
Good question and fair question. I think that many of them are usually sit on the sidelines to see what the big ones are doing and before they make decisions, because they don't have the same level of resources and or implementation footprint in the marketplace. And part of it too is providers don't know or may not be aware of the potential power they have to influence their vendors. And that's what we kind of also try to do, right? We try to advocate for providers. All of the requirements that we usually draft are provider centric and provider specific. What can we do as an industry to ensure that the providers have the data that they need to conduct that interaction with the health plan when they need it? So working with your vendors is something that we often advocate at CORE. Providers need to work with their vendors. They need to help influence their vendors to not only look at what CORE is doing. Obviously, there's lots of folks and players in the industry, and it can be very muddled and confusing. But how do we ensure providers get that data, and that they get that data through often not just the standard, because the standard is often drinking out of a fire hose and it's really complex. But when you train that data through operating roles, you get it specifically to what you need when you need it. So that's some of the challenge that we've had in perhaps recruiting some of the smaller vendors and players when it comes to EHRs or even PMS system vendors. But we do evangelize the work that we do, especially for our provider community.
Okay. Thank you. And
is there any in particular that come to mind for you that you think would be really important to have at the table? We'd be interested in those names, and we are always willing to conduct outreach and make sure we have the right organizations at the table.
Thank you. No, because one of the things that I was looking at as when hearing your presentation was to look at how much of an impact that they have in the way they're presenting some of that information to the providers. And the key stakeholders there as far as how you present it, because at the end of it, if you're missing that arm, everything else will become void. Yes, they do take into, they're impacted a little bit by the clearinghouses, I understand that. But not all of them are clearinghouse dependent on some of the transactions, the way they're initiating things and presenting things. And I think that definitely seems to be a weakness of what I'm looking at in the whole process. Am I wrong?
No, you're definitely right. We have often heard from our providers, well, I submit this and the health plan says they deliver it, and either it gets, massaged by the health plan, by the clearinghouse or the vendor, so it actually doesn't display for the provider. It's coming all the way through, it just doesn't happen to be on the interface that the provider is using. Or the provider doesn't have the ability to submit a specific STC code. The system automatically always just drops to a 30. So there's no way to actually change the STC code to put in, well, I work for a chiropractic office. I don't need to know what your emergency room rates are. I'm here as a specialty provider, and I only want to submit for my special, I only need the benefits for my specialty. So you're right, there is a component for the vendors, for the clearinghouses, for the PMS and the EHR vendors to understand that as requirements are throttled on or off, right, switched on or off, that means there's probably some system remediation that has to take place on their part. They may have to allow more data in and then actually display it so it's usable by the end user, by the provider, or turn it off because it's no longer needed for that specialty. So how do you do that? And that's part of our conversation too. And actually, our core certification program really helps the implementers understand that, because test cases are specific to the data that's coming back in return, and you have to send in screenshots showing that you're actually displaying it. So we get into that level of detail for our certification.
But is the certification more towards the payers, or is it a lot more geared towards the, I know a little bit of clearinghouses. How many of the HR vendors are core certified?
We have a whole list. We have 401 certifications that we just had our 400th this month, complete certification. So we have quite a few, most, I would say, gosh, Aaron, it's probably split between health plans are 50% and clearinghouses and vendors are they're 50% when it comes to the volume of certifications. So about 200 on each side. So quite a few.
And we've done some work developing provider toolkits and provider education on looking for products that are core certified to ensure that those benefits are there. I think one of the challenges is sometimes these provider vendors aren't always considered a HIP covered entity. And so they're not necessarily beholden to the same requirements as everyone else in kind of that trading partner exchange. So it's really about educating the providers, making sure that they are looking for products that are in conformance with the operating rules. And we have a couple toolkits for that and have worked with some of the other provider associations to provide that education.
And one thing that we do as well is that we do publish the name of every entity that is certified and what level of certification, what service that they have that is certified. So that's all available for free on our website. So we do have that. We make that source available for providers.
Thank you.
Just as a quick way of looking at the benefits of adoption for eligibility, you see that reducing the time frame and verifying information is really important. We do provide all of that more granular information and data that you need when a member is present in the office. Again, looking at telemedicine in particular, prior authorization, remaining coverage benefits, procedure level information going all the way down to that level is really important, as well as getting the data back. You should expect more accurate information, more accurate billing practices to come in because you know exactly what data was returned on that eligibility transaction. And then another update that we did was our system availability information. I'm sorry, the way that our system availability requirement previously was 86%. And this was one of the more contentious debates that we had probably in the last 2 years, was to change that system availability to 90% per calendar year. And this ensures that the health plans systems, the front end that providers mostly interface with, especially for eligibility or claim submission, claim status, prior authorization, that is up and ready and going anytime that the provider needs it. So we've increased that 4 percentage points. You wouldn't think it would be that much, but it was highly debated and considered by both health plans and vendors to support health plans to ensure that providers have that access to the information, the data when they need it. We've also included 24 hours additional downtime per quarter because we understand that many larger systems and because of the integration that health plans have with their back-end systems are becoming more complex, might need more downtime when they do those large system turns, and those are generally every quarter. Let's see, I think then obviously some benefits here aligns with technology being 24/7, allowing for longer, less frequent periods of downtime, again, greater access to the system. And as you have better access to the data, you can better serve your patients at the time of service. And this one's a little more technical, but it does align with our latest core connectivity rule. And this allows for not only their traditional kind of SOAP interchange, the normal web interchange that you're most used to, but also allows for the growth in the API technology that's taking place in the industry for that real-time service, real-time access to the data. So right now we all understand eligibility is often in real time, but how do you get claim submission in real time? How do you move to prior authorization in real time? And that's through the technology components. We've updated our technology requirements as well, and these helps align with that because you'll be able to access that data when you need it at point of care, that kind of thing. I know we have a few activities that we're working on. We mentioned course certification, the measurement studies, and ROI, as well as some price transparency work that we're currently doing. I mentioned course certification. That's really important for us. We do ensure that not only do we develop the rule requirements through time, we also advocate for entities to implement them. That's a key component of what we are and something that our board very much supports. So we work really closely with building tools and vehicles for them to certify their systems Not only do they have a one-time certification requirement, there's also a recertification requirement. So you have to go back in every couple of years and make sure that you are still meeting those requirements. Because again, our requirements change over time. We just updated eligibility. So those systems and health plans and vendors will have to recertify on those new eligibility requirements. So you can't stay static. You can't have something that's 10 years old and say, yep, I passed 10 years ago. No, you have to recertify as well. So again, I mentioned we have 401 certifications to date, and this does span from commercial to government to Medicaid to vendors to clearinghouses. All the gamut of vendors that you might be aware of, and many that you probably are not aware of, all going through certification. And at any time, we probably have a dozen or more somewhere in that pipeline that we work with pretty much on a daily basis. We're constantly working with them, helping them figure out how to get certified, where they may have failed in the certification pipeline in that particular test script, and helping them understand how to remediate their system and software.
How often do they have to recertify?
It's every 2 years.
2 years, okay.
It's every 3 years, Bob.
Oh, I'm sorry, every 3 years. I'm sorry, I'm on the 2 year cycle. We're in our second year for recertification. I apologize, every 3 years. We are last 2021 was our first year for recertification. This is our second year for recertification, and next year will be our third year. So we'll have everyone will be recertified next year. So I apologize, it's every 3 years. Everything's been 2 year focus for me this past year. We also have the due diligence with core certification. This ensures that we're working closely within the industry as well as with federal regulations to ensure that those entities that have completed certification feel comfortable in meeting the federal regulations, right? It is a check mark for them that they might feel, I guess, safer when it comes to a CMS audit, because CMS is conducting compliance reviews, not only for the standards, but also for the operating goals. So they will pick random folks in the industry, health plans and vendors, clearinghouses, and look at those HIPAA covered entities and see if they're actually in compliance. And they are conducting compliance reviews, and they're publishing findings on who is not compliant and how they are not compliant. They're often not compliant because they're not using the standard correctly, and they also get dinged if they're not using the operating rules appropriately. So they are publishing these on their website, and the violations are, again, as you see, they're mostly with claim payment and remittance advice, which you can probably, everyone on this call would agree with. There's probably lots of problems still there. Again, we're working closely with industry to fix those issues, but CMS is also looking at these issues. So the certification helps prepare entities for those compliance reviews, because we will let you know when you fail a particular test case. And it goes, again, drills down all the way down to an individual data element.
And Bob and I were both on a conference panel, or listening to a conference panel yesterday with Dr. Mary Green, who heads up the CMS Office of Burden Reduction. And Bob, this was the first time I've heard, or we have not heard of examples of fines being levied for non-compliance to date. It's been really remediation and CMS kind of working with those organizations to ensure that they become into compliance. But she explicitly said that they are looking into their authority to have civil monetary penalties. And so it just felt like a little bit of a change in tone that I hadn't heard before around how they were going to be dealing with non-compliance moving forward.
Yeah, I think the days of a lax CMS when it comes to the penalties, and perhaps it's because they see so many when they've gone through many 2 or 3 cycles of this review process, and they're not seeing any improvements really in the numbers. The same kind of volumes, the same percentages of entities and where they're non-compliant when it comes to the remittance advice, eligibility, and claim status responses. It's the same things happening over and over again. So the industry hasn't been paying too much attention. I think with a couple instances of folks being fined, they'll pay a little more attention to this. As I mentioned, we do have the recertification program is in place. We're working with entities that have completed recertification. We also, again, have our certification helps us identify and measure the industry's progress towards implementing the operating roles, which again, really means the provider is receiving and reaping the benefits of better technology and better data. You may have heard of our CAQH index. We do track and trend this through the industry. We look at the different opportunities there. Sorry, my screen's going crazy on me. Oh, there we go. So we do have the index is available for free on our website. It just allows you to see where the industry is at on any particular transaction when it comes, or interaction, how they've moved from perhaps a more manual process to a more electronic, more automated process. Makes it a lot easier. So we're working with a number of folks in the industry to track and trend that over time. Building on to our other core activities, our ROI and measurement activities. We have a number of pilots that we're working with. And I mentioned Cleveland Clinic and their vendor PriorAuthNow. And yeah, I think we're on slide 24. Yeah, there we go. We're looking not only at what standards are in the marketplace, be it X12 or HL7 or whatever technology that might be or standard, but really looking at how the interaction between the provider and the plan is working. How well is it working? How automated? How many touches does it take? How many manual clicks does it take? We drill down to that level in our study. We look and we have seen where an associate in a provider's office is touching this PA 12 times. It's this many minutes. It accounts for this many dollars. That's what we're drilling down to in our pilots. And we're really looking at what that might mean for the next level of operating roles. Where else can we need to work at? We've done that quite a bit for PA over the last 2 years. Our priorities for this year is attachments, looking at them either for PA or for claims. And we're also looking at value-based payment opportunities. So again, if any interest in that, either of those spaces, let us know. We're always interested in looking at and finding folks, recruiting folks to help us understand some of these inefficiencies and then how you're actually making changes today. Right, there's no federal regulation for attachments. So what are you doing today to improve what it was yesterday to what it's going to be tomorrow? Is there things in play that we can help better understand? So part of that is always kind of spelled out on the next slide. We put together an approach. We engage with our partners. We run the pilots, but we'll help you run the pilots. We have staff. We've prior to the pandemic, we flew to Cleveland Clinic and sat there for half a week and helped set up the study. And we met with staff and we worked with them directly in their cubicles to understand exactly what all those touches were. And then we actually run quite a bit of reporting. We analyze the metrics, we publish this, we educate the industry on them. You'll see a couple of webinars that we've done with Cleveland Clinic already. We have a white paper that's about ready to be released, walking through what those requirements are as well. And again, just an example of the case study. Some of the findings that we did most recently with the prior authorizations. Turnaround time is reduced 25%, went from touch to touchless. Faster approvals, almost 8 days faster to get the PA approved. Again, when you used to work on a fax machine, a fax server-based process to a fully automated, integrated with your EHR and PMS system, it reduces that time quite a bit. With that, I'll hand the call over to Aaron to take over the next couple of items. Any questions?
Another area where we're hearing a lot of need across the industry is around some of the price transparency efforts that are going on. We have had a number of conversations with our participating organizations and actually convened an advisory group last August to think through how, in particular, the advanced explanation of benefit requirements in the No Surprises Act could be met using standards and potentially operating rules. And out of that work came a issue brief with some recommendations on how to support the provider to payer exchange of a good faith estimate, thinking through connectivity protocols, messaging standards, and what data is needed to do that successfully. We are kind of moving into the next phase of that work. Last week, we held a focus group, and this is it's an interesting and evolving topic from particularly an operating rule perspective, because the requirements are out for providers to share that good faith estimate information with self-insured or self-pay patients. However, the industry is still waiting for additional guidance, particularly related to standards to use for the advanced EOB process, and that's the process for insured patients when there's a health plan involved. And so it's been really interesting talking to our colleagues across the industry, because last week we held a focus group open for all of our core participating entities, and we tried to do some polling and discussion-based work, and the providers were really engaged, and the provider vendors were really engaged in talking about how they were thinking through workflows and processes to provide that good faith estimate, particularly to the self-insured patients. Once we started trying to push the plans to talk about where they were in terms of readiness, it was very clear that the plans haven't gone as far down the path for planning yet. They are certainly waiting on more guidance from CMS and industry. There is some work being done by HL7's Da Vinci project to develop a patient cost transparency implementation guide that would support the advanced EOB workflow using FHIR. And they were working with X12 on that. From an operating rule perspective, operating rules really fill gaps in the standards. So it's a little bit early from our perspective for us to start thinking about what role operating rules could play. We really need the industry to begin implementing in the real world setting to understand where there might be needs and gaps. But we want to stay on top of the topic, and I think it's been helpful to serve as a forum for industry to come together and discuss some of the challenges and opportunities they're seeing as they develop this. So our plan is to do a series of 3 focus groups this year with our participating organizations, followed by open industry webinars where we share some of the findings from the focus groups and have some industry experts come in and speak. I know HBMA has been doing some work in this space too. I saw some emails around No Surprise Act webinars as well. So I think, I guess I already talked about all of the work that the focus group is doing. This slide summarizes all of that. Can I pause here and just kind of ask what's going on from your perspective in terms of preparation and readiness for some of these requirements coming through?
We just completed a series of 3 webinars that focused on the good faith estimate. And then the one we did yesterday was on the mediation process. So we've got the basic information, but like you said, Aaron, there is still a lot of unknowns out there. So we will continue looking at this. I don't know, Tim or Ramesh, is there anything else that you would say about what's going on in terms of how we're educating members?
We are basically in our subcommittee meetings with each of the payers. We do talk about some of the NSA regulations, how they're implementing them and all of that, and get a better feel for what their policies are doing and how they would implement the the pricing, etc., and all of those things.
Yeah, I think there's a huge swing in terms of level of understanding and preparedness, and when it comes to things like the advanced EOBs, I think that's further down on the scale, and so there's less education and discussion about it, though to Brad's point, it was brought up and discussed in one of those 3 sessions, but there's just a broad variance from member company to member company in terms of their understanding and involvement and what they need from us as well as other sources to get there.
Yeah, absolutely. I think there's some organizations that are still hoping these requirements might just go away if they keep, going through courts and things like that. But others are much further down the path. I think, from Bob and I's perspective, this is really an area, and particularly those advanced EOB requirements, where if every organization goes out and does something different and it's not standardized, it's going to be a very costly and expensive effort for the industry. And that's hopefully not where I think most of us want to see it go. So that's kind of key to why we're tracking and keeping our eye on things. That would be less than ideal.
You raise that point in relation to advanced EOBs, which is from it feels to me like it's further down the path in regard to NSA components than, for example, one of the components is that the payers are supposed to provide the 3 pieces of information when making payment or denial. They're supposed to provide the QPA. They're supposed to provide a certification statement that it was developed in compliance with the guidance. And probably the most important component is they're supposed to provide a contact phone number and or email for open negotiation. All 3 of those things we see extremely little standardization or implementation of. And when I talk to the clearinghouses, they say, well, we're leaving it up to the plans, or we're having conversations with the plans. And yet this was all supposed to happen beginning January 1st, and it's happening in stages, in different ways, and largely not happening. And I'm very curious as to how you're dealing with that, which to me is a little on the front side versus, the advanced EOBs.
That's a good question. I have not heard that come up in any of the industry groups I've been attending. So I have put a note here to do a little digging in that space. Bob, have you heard anything? You're on mute, Bob.
I agree with Aaron. I think that most of the focus for the conversations that we hear from is from the provider perspective, and not necessarily what the health plans are doing to meet those specific requirements. They're really being, playing mute. I mean, they're playing like they have no requirements, and they're just pushing everything off the providers, as you can imagine. So it's definitely something we can drill into, and I'm sure our board members are working on, have specific topics or projects already in the works to meet those types of requirements. We can definitely come back with some more information from our findings.
We can easily share the the documentation of the expectation with you.
Perfect.
If it wasn't on your radar, and see, what comes of it.
Yeah, anything you have on that would be great.
Okay.
Just to wrap things up, the other thing I wanted to highlight, and this has happened since we developed these slides even, is that our board did submit a letter to the National Committee on Vital and Health Statistics, and that's the federal advisory body to HHS on areas related to administrative simplification, including operating rules. And that letter included a package of operating rules that we are asking NCVHS to consider for federal mandate, and it includes some of the new and updated operating rules, or all of the new and updated operating rules that Bob reviewed today. So I think, having some standardization around attachments, whether we get the standard or not, will be critical, but also updating some of the currently mandated operating rules for eligibility and connectivity, bringing those into current day business practices is going to be really important for the industry as well. Right now, the rules, in particular connectivity, are requiring kind of older, outdated protocols, and there's a real need for those requirements to move into, as some would say, the next century.
Is that going to be on the agenda for, we're participating in the NCBHS meeting on June 9th. I haven't looked at the agenda, but is this, these topics going to be on the agenda?
Not these operating rules in particular. So when we send the letter, it does trigger NCBHS to plan for a public meeting. But on June 9th, they are talking more specifically around how can they improve the general processes of HIPAA standards and operating rules. So
Okay.
I think there's been a lot of feedback from the industry that and I would say just from our perspective and other SDOs, we have all worked very hard internally to increase the pace of our work. However, HHS and CMS, that whole federal process still takes 3+ years, you know, from the time we submit a letter until organizations are actually implementing and using the updated standards or operating rules. So I think there's going to be some discussion around how can we improve that so that organizations are able to use the most current, you know, standards and requirements that are available. I think there's going to be some discussion too on exemptions. How do we test and measure the value of new standards potentially like fire and relative to some of the existing standards? So Brad, we can connect separately because I know April, the SVP of CORE, is participating in panel 1, and she and I both are on panel 3 on the 9th as well. So happy to connect with you on that. Should be an interesting discussion.
Yes.
All right. I think that pretty much summarizes everything we had for you all today. We are happy to answer any additional questions, but I know a lot of these topics we would really welcome your all's participation and engagement in our work groups. As Bob mentioned, we have the code combinations. The Carks and Work group meets regularly throughout the year. We are doing these focus groups related to the No Surprises Act requirements, as well as probably starting some work on claims later this year and potential new operating.
Oh, Aaron, did you freeze up?
Oh, am I back?
Oh, there you are. Yeah, you're back.
So the thing I haven't mentioned to you all is we've been under a tornado watch this whole time.
Oh my.
And the storm is about here. So we're ending at just the right time.
Okay. Ramesh, do you have something?
I just had a quick question on how we might be able to work together if we decide to work together. And that would be one of the things is, would you, I mean, I know that you want us to participate in some of those meetings, that's good. But in a voice of thousands would be sort of shut down completely. Is there a way that you can work with us a little more like in a subgroup or something as such where we create a subgroup and we are able to discuss a few things? Or how exactly do you envision this relationship to happen?
I think there's a couple different ways. One would definitely be participating in our existing groups. I don't think your voice would be shut down. I think it would be very welcome. And then also, I mentioned our environmental scanning. That's really where we dig in to understand what are the critical issues and challenges in the industry right now that could be addressed by operating rules. And so this year we'll be doing interviews related to claims, value-based payment opportunities, practice management, and EHR system integration. And as we dig into that work, we'd love to have our teams meet either one-on-one or with a group of HBMA members to kind of do some root cause analysis work there. And then certainly we're happy to collaborate in any other way that would be helpful for you all, whether it be education or otherwise.
Ramesh, would it be helpful, and Aaron, I apologize if you've already done this, but if there's a list of work groups that you feel would be relevant to the work we do, then Ramesh, I think we could take that list of work groups and see if we can get people assigned to them.
True, but I think it would make better sense to see if we could have someone we are working with in relationship, just like we do the subcommittee meetings. We'd have a separate subcommittee and in that discuss each of the different aspects of what they're coming up with in more detail and see how we might be able to influence the process at this end through the team at to your team as such, and then go from there. So in other words, having a regular meeting with the subcommittee of our HBMA members, would it help you to make a better difference?
Do you have any particular areas that you would like us to focus on? Again, that could be for Ramesh or Aaron or Bob.
Yeah, I think definitely the correctional works task group might be helpful to get the perspectives. The advanced EOB work that we're doing, the integration project that we have between EHR and PMS.
Yeah, that caught my attention because you recall we have this association of practice management systems, and I found that even within companies like NextGen or Gateway, the EHR was separately. There was no integration at all going on there.
At all, yeah.
Interface at best.
Yep.
Okay. I think we've got an idea of where we can go with the work groups.
I would also, I hate to interrupt, but another suggestion. We do this with several other participating organizations. Meetings just like this, where we co-educate each other on our topics, as well as quarterly meetings. We set up quarterly calls with a lot of our participating organizations just so they can, let us know what we don't know, right? And where else can we participate? And co-educational opportunities. I know we'll be presenting at your annual conference. Those things are also help us to integrate with each other to really understand some of the challenges that we have.
That might be an area, Ramesh. Like the Commercial Payer Relations Committee, they meet on a monthly basis, and then each quarter they also meet with each of the 4 health plans that participate with us: Humana, Aetna, Cigna, and United Healthcare. And then once a quarter, we bring all 4 of those health plans together in a single meeting. Those 4 health plans are also going to be presenting in a panel at our fall conference. So we do have a lot of meetings, but Ramesh, that might not be a bad idea if we were to set up a quarterly meeting with Aaron and Bob, and we maybe could start broadly. But I think the idea for that meeting would be for us to maybe provide information to you that you may not be aware of, or it's not working from our perspective. What do you think, Ramesh?
Exactly. That's where I was coming from. With the core of my questions also were focused on that area, that aspect itself, and I think we are seeing eye to eye there. Okay.
The last thing that I have, again, going back to your list of practice management systems / EHRs, there are a lot of systems that participate with HBMA that were not on your list. I think that we can probably start talking to these PM systems and get them to be more interested in becoming core certified for the benefit of our members.
That'd be great. And then let us know. We can help be part of those conversations, or whatever tools or collateral we can send your way to help.
Okay, will do. And Alicia, do you have anything that you want to comment on or ask? Alicia's she's in the weeds and all these things. She is the doer, whether it be for provider enrollment and that sort of thing. Do you have anything for the group?
Not in regards to this review today. No, I don't.
Okay.
Thank you.
Well, and why don't you give them a happy long holiday wish, because Bob, I know I mentioned to you that I got a lot of pushback when it came to ProView, that our members didn't seem to like it or use it. And I talked to Alicia about it, and she said she's been using it for a long time and it works fine. So is that still the case, Alicia?
ProView and well, the other the EFT account, the solutions, I know that's sunset, but ProView we use regularly because it's the main credentialing tool for a lot of the bigger payers. Aetna, Blue Cross, Blue Shield's using it now, Cigna, Magellan, MHN, United Healthcare, just to name a few. There's a few bumps and suggestions that I have for that portal, but all in all, I think it runs pretty smoothly.
And I know we can definitely bring over resources from that side of our house that manage the ProView. We have product managers that are always interested in learning where the bumps are and what we can't do to help mitigate some of those issues that you're having.
Yeah, the main concern is the if there's any change in the sort of security, the access to the account. I noticed, a lot of websites, if not all, are upgrading their account security for user access. And so that would be one of the main discussions I would like to have with somebody to see what's on the horizon for that. And just a couple of like little technical things that I think they could work out a few bugs with programming, but they're minor.
Bob and Aaron, I had a separate conversation with Robin about, the surrogate program. And she told me there is, that's in the works. So what Alicia's talking about is that she may have 50 different practices that she's doing provider enrollment for, and she has to have the username and password for each one of them to get in.
Right.
Where the surrogate program would eliminate that.
Yeah, single sign-on might be helpful when you have those delegated accounts. Yeah, we're definitely working on the delegated provider process.
Okay. Well, this has been wonderful. And Bob, I'm looking forward to greeting you in St. Louis in September.
Looking forward to it.
And I hope that your daughter's graduation went well.
It went really well. Thank you.
Okay. Well, thanks so much, Aaron and
Thank you.
Bob.